My name is Erica McKnight, and this is my cardiovascular pulmonary assessment video. Before I would do any assessment to my patient, I would explain to them what I was going to be doing. I would introduce myself and do hand hygiene and provide privacy and observe universal precautions. So first of all, in my assessment, I would inspect my patient. For the cardiovascular part of this assessment, first I would assess for jugular distension. So I would examine the patient's neck, make sure that I don't see any abnormal distension of the jugular vein. And then next I would inspect and palpate the carotid artery. When palpating, you want to avoid the carotid sinus up here because that can cause syncope and all kinds of other bad stuff. So when assessing that, it'll be down here lower. And his carotid artery, it has a nice, strong, regular pulse. And I will listen to the carotid pulse using both the bell and the diaphragm of my stethoscope on each side. And his carotid pulse is strong and equal bilaterally. So next we'll move on to heart tones and heart sounds. First I'll begin by assessing, just observing the chest area, make sure that his breathing is equal, make sure nothing's labored, he's not struggling to breathe, not using any accessory muscles or anything like that, which he's not. So I'll go ahead and just explain the landmarks of what I'll be listening to. First, I'll start in the second intercostal space, right sternal border, and listen to the aortic valve, and then I'll move to the second intercostal space on the left and listen to the pulmonic valve. And I'll move to the fourth intercostal space and listen to the tricuspid valve. No, the pulmonic valve, sorry. Pulmonic valve, and then move to the fifth intercostal space and listen to the tricuspid valve. And there I will listen to the apical pulse for 1 minute. And I will use the bell and the diaphragm of my stethoscope for each landmark. You just breathe normal. And for time purposes, I'm just going to listen to the one side for the apical pulse. His heart tones are strong and regular. They're unremarkable. And I did not hear any abnormalities. So next, I'll move to the anterior lung sounds. And again, I would assess by inspection first, noting if there was any labored breathing or if he had any complaints or anything like that. So for the next part, I'm going to palpate the anterior side just to see if there's any tenderness, and I would explain to the patient that they would need to tell me if there was any tenderness as I palpated. So tell me if there's any tenderness. And he says no. Next, I'm going to assess tactile firmatones. And so I'm going to place my hand in each quadrant of the chest here and have him say the word 99. So as I do this, every time you say 99, say 99.
99, 99, 99, 99.
And here, his vibrations of him saying the word 99 were equal to the vibration that I felt on my hand. So no abnormalities there. Next, I'm going to assess the anterior lung sounds, starting with the inner 1/3 of the clavicle. I will use the bell side of my stethoscope to assess that. So each time I put my stethoscope on your skin, take a breath in and out for me. Good. Next, I will go to the second intercostal space, and I'll move from the right side to the left side. I'll go to the second intercostal space, the fourth intercostal space, and the sixth intercostal space bilaterally. So each time that I place my stethoscope on your skin, just take a big deep breath in and out for me. And his lung sounds are clear and equal bilaterally. So I'm going to have him stand up and turn around so I can do posterior lung sounds. So if you'll turn around for me. If you'll just, yeah, just put a chair there. There we go. Okay. For this part of the assessment, I'm just going to listen to the posterior lung sounds, starting with T1, which will be above the scapula, T3, which will be top of the scapula, T7, which will be the bottom of the scapula, T9, lateral to the vertebral line, and then T9, posterior to the axillary line on each side. So I'm going to go ahead and listen to those. And each time I place my stethoscope again, just take a big deep breath. And his lung sounds are clear and equal bilaterally again. So for the last part of this assessment, I'm going to percuss the posterior side here. So I'm going to place my hand here, and then I'm going to tap 2 fingers in between here. So here you are just listening for kind of a hollow sound. You want to avoid hitting the scapula because doing it on a bone can sound dull, and that's kind of what you're assessing for. Any dullness can, mean that there's some sort of abnormality there. So avoid the scapula, listen for a hollow sound, and I did not find any abnormalities on him. So this completes my cardiovascular and pulmonary assessment.